Today's subject is the hand. Let's start. First, let's look at the bones of the hand. On the left-hand side of the image are the bones of the hand as seen from the palmar side. On the right-hand side of the image are the bones of the hand as seen from the back or dorsal side of the hand. The wrist bones are now labeled. These are the bones that are immediately distal to the two forearm bones, the radius and the ulna. Distal to the carpal bones are the metacarpals. These are the bones that make up our palms. Note the numbering on the metacarpals. The thumb metacarpal is labeled 1, and the rest of the metacarpals, moving from lateral to distal, are labeled from 2 to 5. The same scheme is kept for the digits, or the fingers. Finally, the most distal bones of the hand are known as the phalanges. One bone is known as a phalanx, whereas a plural is phalanges. Note the first digit, the thumb. It only has 2 phalanges. The joints of the hands are also given names. For example, where the metacarpals meet the phalanges, these joints are known as metacarpal phalangeal joints, or MP for short. Where the first phalanx of any digit meets a second phalanx, that joint is known as the proximal interphalangeal joint, or PIP for short. And finally, where the intermediate phalanx meets the distal one, the joint is known as the distal interphalangeal joint, or DIP for short. The thumb only has one interphalangeal joint, or IP for short. Let's discuss some clinical scenarios of the bones of the hand we just described. Metacarpals, except for the first, are closely bound together. Hence, isolated fractures of these bones tend to be stable. Metacarpals have good blood supply and will heal quickly. Fractures of the necks of the first and second metacarpals are often referred to as boxer's fractures. In unskilled street fighters, the neck of the more mobile fifth metacarpal is commonly broken. This is because street fighters rarely tighten their fists before they punch. However, it is incorrect to assume that fractures of the metacarpals are rarely insidious. Severe crushing injuries, for example, of the hand may produce multiple metacarpal fractures, resulting in instability of the hand. This is a serious complication that needs to be treated. Let's now describe another injury that can occur specifically to the thumb and its associated ligaments. The injury is called skier's thumb. Although the injury was originally called gamekeeper's thumb. The injury results from hyperabduction of the metacarpal phalangeal joint, for example, when the thumb is held by the ski pole while the rest of the hand hits the ground and enters the snow. Why was it called gamekeeper's thumb? Apparently, the repetitive action of snapping a game bird's head, if done sufficiently, brought about the same type of injury. While this may sound unbelievable, recall that it was said that flocks of passenger pigeons numbered in the billions, but were eventually hunted to extinction for food and sport in the late 19th century. Presumably, the hunters were breaking millions of necks a year of the birds who had been shot, and in time, some of the hunters experienced this type of injury. There is another injury that is common to the thumb. It is called bull rider's thumb and it was frequent when mechanical bowls used to be placed in drinking establishments as a means of entertainment. The thumb would be caught and the rider would be thrown off the bull, resulting in bull rider's thumb. This injury is characterized by a sprain of the radial collateral ligament, shown in the slide, and an avulsion fracture of the lateral part of the proximal phalanx of the thumb. Clearly, the moral here is that one should not ride and drink, and that is no bull. We now get to the carpal bones, the bones of the wrist. These bones are arranged as two rows, a proximal and a distal row. You should learn their names. On the proximal row, going from lateral to medial, we find the scaphoid, the lunate, the triquetrum, and the pisiform. The distal row consists of the trapezium, the trapezoid, the capitate, and the hamate. The Latin translation for each bone is given in parentheses. Now look and see that the scaphoid and lunate bones are the only carpal bones that articulate directly with the radius. This is also clearly shown in this film of the wrist joint. What is clinically relevant about knowing that the scaphoid and lunate are the only bones that articulate directly with the radius is that the scaphoid is the most frequently fractured carpal bone and is the most common injury of the wrist. Pain occurs primarily on the lateral side, on the side of the thumb. The fracture may not be detected in initial radiographs. Repeated radiographs may reveal the fracture site if bone resorption occurs. The proximal part of the scaphoid bone is poorly vascularized and may take several months to heal after a fracture. Indeed, it is said that the scaphoid bone receives its blood supply in a retrograde fashion. Degenerative joint disease of the wrist may result. It may even be necessary to fuse the carpal surgically if they do not heal. One particular fracture of the distal radius and ulna is known as Colles fracture. Fractures of the distal end of the radius are the most common fractures in adults older than 50 years. This occurs more frequently in women because bones are weakened from osteoporosis. The fractures occur when patients try to break force of a fall and land on a partially abducted extended hand, as shown in the image. A complete transverse fracture of the distal radius is called a Colles fracture. In these cases, the distal fragment is displaced dorsally and is often comminuted, broken into little pieces. In 40% of cases, the ulnar styloid process is avulsed also, or broken off. As seen from the side, on the right hand of the image, the distal fragment of the radius overrides the rest of the bone in these type of fractures. It is called a silver fork deformity because the arrangement of the distal hand with the radius and ulna resembles that of a fork. A similar looking deformity occurs when children fracture their wrists. The fracture, however, occurs at the distal radius epiphysis, and this is a common injury in children. The injury results, again, from a fall on the open hand with the wrist extended and abducted. In the lateral film, the dorsal displacement of the distal radial epiphysis is obvious. This concludes the discussion of the bones of the hand, so now let's move to the soft tissue of the hand. Deep to the skin, on the palmar side of the hand, a tough and fibrous fascia, the palmar aponeurosis, anchors the skin to the deep fascia. The palmar fascia is thin over the thenar and hypothenar eminences, but thick centrally. The proximal end is triangular in shape, as shown on the left hand of the image. The distal end divides into 4 digital bands and attach to the proximal ends of the phalangeal bones. For unknown reasons, although a genetic component is implicated, a progressive shortening, thickening, and fibrosis of the palmar fascias and aponeurosis may occur. This is known as Dupuytren's contracture. The contractures usually occur bilaterally and are more frequent in men over the age of 50. Disease usually begins in the medial region of the aponeurosis as a painless nodular thickening that adheres to the skin. Treatment usually involves surgical excision of all fibrotic parts of the palmar fascia to free the fingers. The thick and strong palmar aponeurosis is also responsible in the way that swellings resulting from hand infections usually present. Swellings of the hand usually manifest themselves on the dorsum of the hand, as shown in the image. If the infection goes untreated, it usually spreads via carpal tunnel to the forearm compartment with insidious consequences. Let's continue our examination of the soft tissue of the hand and look deep to the palmar aponeurosis and examine the flexor retinaculum, or the carpal tunnel as is commonly known. 4 carpal bones make up the boundary of the palmar aponeurosis. On the ulnar side is the pisiform, and distal to it is the hook of the hamate, or the hamulus. On the radial side we find the scaphoid, and distal to it is the trapezium. These are the 4 boundaries of the carpal tunnel. The function of the carpal tunnel is to provide mechanical advantage to the tendons of the muscles of the forearm during contraction. Let's look now and see what goes through the tunnel versus what passes into the hand from outside the tunnel as an anatomical explanation of what carpal tunnel syndrome can be. Look at the image and observe that the ulnar artery and nerve do not pass through the tunnel. Both lie anterior to the flexor retinaculum. The radial artery also lies anterior to the retinaculum. In contrast, clearly shown in the image, although not labeled, is the median nerve. Thus, carpal tunnel syndrome must, by definition, be an affliction of the median nerve. The next objective is to describe the muscles that move the fingers. But first, let's look at the action of the fingers in anatomical terms. As shown in the image, the fingers can flex, or they can extend. They can abduct, that is, move away from the middle finger, or they can adduct when they come back towards the middle finger. In the hand, the middle finger serves as the frame of reference. The thumb also moves as the other fingers do, and it can abduct, adduct, extend, and flex. But in addition, the thumb can oppose, that is, move towards the other fingers, and the balls of the fingers can touch with the thumb. Once you become familiar with the movements of the fingers, the next objective is to look at the muscles that move the fingers. These muscles are arranged as layers in the hand, and I will describe them to you as layers. We'll start with the first layer. There are 2 prominent bulges deep to the skin on the palm of the hand, and these bulges represent muscles that are present either on the thumb side, the thenar eminence, or on the small finger side, the hypothenar eminence. Let's look now at what makes up these muscles. On both eminences, we'll have an abductor. On the thumb side, we'll have an abductor pollicis brevis, and on the hypothenar eminence, we'll have an abductor digiti minimi. After passing through the carpal tunnel, the tendons of the flexor digitorum superficialis can be observed in the first layer of muscles. Before continuing with the muscles, let's take a detour and describe prominent features that are superficial in the hand. In particular, let's look at the superficial position of arteries that leads to their frequent injury. As well, branches of ulnar and median nerves are all cutaneous in this region. Another structure that's quite prominent in the palm of the hand, and it's quite superficial, is the recurrent branch of the median nerve. The superficial distribution of this nerve is the reason for its frequent injury. In fact, it is a common injury when trying to slice a bagel. When you flex your middle finger and place the ball of the finger on the thenar eminence, it will demonstrate precisely the surface location of the recurrent branch of the median nerve. Loss of the nerve leads to simian hand syndrome, that is, the inability to oppose the thumb. Let's now continue and describe the muscles found in the second layer. On the thenar eminence, we find the opponens pollicis, and next to it is a flexor pollicis brevis. Finally, there's a tendon of the flexor pollicis longus. This tendon passed through the carpal tunnel also. On the hypothenar eminence, we find the opponens digiti minimi and the flexor digiti minimi. Oftentimes, these two muscles are fused and are quite difficult to discern in the cadaver. Also prominent in this layer are the tendons of the flexor digitorum superficialis and the flexor digitorum profundus. We can also observe the lumbricals, worm-like muscles that are attached to the tendons of the flexor digitorum profundus. Let's now look at the arrangement of the flexor tendons and sheaths of the flexor digitorum superficialis and profundus as they pass from the palm into the digits. Look at a sample tendon of a flexor digitorum superficialis. Note in the center image and on the image on the right that the tendon of the superficialis flexor digitorum only extends past the proximal interphalangeal joint. Therefore, the flexor digitorum superficialis only flexes at the level of the proximal interphalangeal joint. Now, look at a tendon of a flexor digitorum profundus. Note that these tendons extend past the distal interphalangeal joint. Thus, the tendons of the flexor digitorum profundus function to flex the distal interphalangeal joint. To review, the tendons of the flexor digitorum superficialis act at the level of the proximal interphalangeal joint, whereas the tendon of the flexor digitorum profundus act at the level of the distal interphalangeal joint. But what about the lumbricals? What is their function? As mentioned earlier, the lumbricals are worm-like muscles, and they originate from the tendons of the flexor digitorum profundus. There are 4 lumbricals, numbered 1 to 4, and their action is to flex the metacarpal phalangeal joint, but to extend the proximal interphalangeal joint. We're now ready to look at the third layer of muscles of the hand. In general, we say there are 3 ventral interossei muscles and 4 dorsal interossei muscles located between the metacarpal bones. In addition, there's an adductor pollicis. In general, the action of the interossei can be summarized as follows. The palmar interossei adduct the digits, whereas the dorsal interossei abduct the digits. Remember, the reference point for abduction and adduction of the digits is the middle finger, as shown in the figure. We're now ready to look at the nerves of the hand. First, we'll look at the motor components. As a reference, there is the hook of the hamate and the pisiformis, 2 carpal bones. And now, shown labeled, are the ulnar nerve and the median nerve. Recall what we said earlier. The ulnar nerve does not enter the carpal tunnel, whereas the median nerve passes through the carpal tunnel. Immediately after passing through the carpal tunnel, the median nerve gives off the recurrent branch of the median nerve to the thenar eminence. Recall the surface location of this branch. The median nerve also gives off 2 motor branches to the first 2 lumbricals, as shown in the slide. The ulnar nerve also provides motor branches to the muscles of the hand. It does this by way of the deep branch of the ulnar nerve, and this branch extends all the way to the adductor pollicis muscle shown previously. The rest of the nerves shown in the slide are all sensory. We will discuss their distribution in just a short time. Now let's look at the deep branch of the ulnar nerve once again. The deep branch of the ulnar nerve is motor to all the interossei, both the dorsal and ventral interossei, as well as the adductor pollicis, that is the muscle that adducts the thumb. Now that we have finished looking at the motor distribution of the median and ulnar nerve, let's look at the cutaneous nerves of the hand, and specifically the usual situation. Understand that there are numerous variations on this theme. The cutaneous distribution usually served by the median nerve is shown in purple. It is usually said that the median nerve serves 3.5 digits. The half digit is the ring finger of both hands. In contrast, we say the ulnar nerve is the 1.5 digit. It does the little finger and half of the ring finger. Remember, we're only talking about cutaneous innervation at this time, not motor function. The radial nerve also does some cutaneous innervation of the hand. This area is shown in pink. Let's look now and see what happens when some of the nerves that we have been discussing that regulate muscle action in the hand are severed. Median nerve lesions usually occur in 2 places, in the forearm while crossing the pronator teres, and at the wrist while in the carpal tunnel. A variation of this latter theme will be if the recurrent branch of the median nerve is cut at the level of the thenar eminence. The appearance of the hand will be very different if the median nerve is injured at the level of the pronator teres or at the carpal tunnel. Let's have a look. In carpal tunnel syndrome, the area of the tunnel is reduced in size due to inflammation, whether from infection or possibly excessive exercise. The median nerve can also be injured at this location by accidental laceration of the wrist. If the injury of the median nerve occurs within the carpal tunnel, paresthesia, hypoesthesia, or anesthesia may occur in the lateral 3.5 digits, the cutaneous area of the hand served by the median nerve. As well, progressive loss of coordination and strength of the thumb may occur. This is because the recurrent branch of the median nerve to the thenar eminence will be impacted. This condition is described as ape hand or simian hand because the thumb now appears almost totally adducted and is unable to oppose. Indeed, the main characteristic exhibited by persons with median nerve compression at the level of the carpal tunnel is that they will be unable to oppose the thumb. However, because thumb flexion and extension and thumb abduction and adduction are controlled by nerves not located within the carpal tunnel, these actions of the thumb will not be affected. It is true that there is a flexor pollicis brevis and an abductor pollicis brevis within the thenar eminence, and this will be affected if the median nerve is impaired at the carpal tunnel. But remember, abduction of the thumb is also achieved by the abductor pollicis longus that is innervated by the radial nerve, and the muscle belly of the flexor pollicis brevis is innervated by the median nerve in the forearm, not at the carpal tunnel. However, if carpal tunnel syndrome is left unchecked, then the condition can progress into the forearm and sensory changes will radiate into the forearm and the axilla as well. If the median nerve is injured at the elbow, however, then other muscles regulated by the median nerve come into play, and besides inability to oppose the thumb, digits 2 and 3 are now fully extended. The appearance of the hand in this syndrome is known as the papal sign. What happens in this lesion is that the muscle bellies of the flexor digitorum superficialis and profundus, the radial side of the latter, are unable to help flex the fingers. In addition, the first two lumbricals, capable of helping to flex the metacarpal phalangeal joint corresponding to these two fingers, are now also de-innervated. In contrast, all of the other intrinsic muscles of the hand, the dorsal and ventral interosseae, the adductor pollicis, and the ulnar two lumbricals remain functioning. Thus, one can fully flex the ulnar two fingers of the hand if the median nerve is injured at the level of the elbow. Let's move now to the ulnar nerve injuries. These type of injuries usually occur at 4 locations. Posterior to the medial epicondyle of the humerus, likely due to trauma. By the way, this is considered the funny bone because it is quite humoral to bob yourself at the elbow. The second location is at the cubital tunnel formed by the tendinous arch connecting the humeral and ulnar heads of the flexor carpi ulnaris. These types of injuries are the result of repetitive types of injuries and may be considered occupational hazards. The ulnar nerve can also be damaged at the level of the wrist as the result of trauma. For example, suicide attempts often sever the ulnar nerve. and the ulnar nerve can also be damaged at the hand by compressing it as a deep branch of the ulnar nerve travels by the hook of the hamate. This condition is often given the name of cyclist palsy. Injury to the ulnar nerve may result in extensive motor and sensory loss to the hand with accompanying impaired power of adduction of the fingers. On flexing the wrist joint, the hand will be drawn to the radial side by the flexor carpi radialis in absence of balance provided by the flexor carpi ulnaris. Patients are likely to have difficulty making a fizz due to paralysis of the intrinsic hand muscles, in particular all the interossei muscles. The metacarpal phalangeal joints become hyperextended, and patients will be unable to flex the fourth and fifth digits at the distal interphalangeal joint. Patients also will not be able to extend the interphalangeal joints of these fingers because the ulnar lumbricals are affected. The condition is known as claw hand, perhaps because the hand resembles the talons of a large predatory bird. Damage to the radial nerve will also impact the appearance of the hand, although the radial nerve supplies no muscles in the hand. Injuries may occur as a result of fractures of the humerus, for example, where the nerve lies in contact with the bone at the radial groove indicated by the number 1 in the image. The characteristic appearance of the hand is that it is fully flexed. This is because injury to the radial nerve at the level of the humerus will impact all of the extensor muscles located at the level of the forearm, whereas all the flexors are spared. This condition is known as wrist drop. This now concludes the lecture on the hand. Bye-bye.